Okay. I'd like to introduce our feature presentation, and it's from the Mental Health and Wellbeing Commission. So we're very, very lucky to have people to come along and talk about some of their work, but particularly we've got Jacqui Gibson, who's a commissioner and representing carers, and also Kaaren Dahl as well, as an assistant commissioner at the Mental Health and Wellbeing Commission. So I'd like to thank you so much for coming today, and I'm sure there'll be lots of questions, but I was just going to say, basically, particularly people online, if you could put your questions in the chat while Jacqui just sort of talks through her presentation, and then we'll address them after. So thank you. Thank you so much, Jacqui.
Is that okay? Oh, no. Is that better? Perfect. Right. A bit short. Essential that you times oneself when talking, otherwise I'd be here all day, and I'm sure that we've all got better things to do. So I am your Carer Commissioner, and it is an absolute delight to be here. Before I begin, I'd like to acknowledge that we're on the lands of the Wurundjeri people of the Kulin Nation, and I pay my respect to elders past and present. I also wish to recognise and celebrate the individual and collective expertise of people who care for a person with a lived or living experience of mental health challenges and recovery, and thank them all for their contributions in helping to reform our mental health system. So there I am. It's a great photo, only taken a few weeks ago. Failed to smile, and my mother has not stopped telling me, "That's a very bad picture, love. What were you thinking?" However, it's the photo that we have. It's wonderful to be here in Carer Week adjacent, I'm going to call it, since it was last week. But it was lovely to be here so close to Carers Week, an opportunity to celebrate the resilience, dedication of carers, families and supporters, while reaffirming our commitment to a more compassionate, inclusive, individualised approach to mental health and wellbeing in Victoria. And I think the last presentation is a gentle reminder of why we need to be a bit more inclusive and compassionate. I'm going to give you a brief outline of what's going to be covered today, and hopefully we'll stick to time. And Kaaren, our Assistant Commissioner, is going to answer your questions about complaints at the end, because I know that's a hot topic for everyone. I can't say that having only been in this role since the 1st of September officially, I'm completely across complaints, but I think it's always good to bring along an expert on the issue rather than to perhaps give you some false ideas. So I'm going to talk about the function of the Mental Health and Wellbeing Commission, an overview of the role of the Lived Experience Carer Commissioner, discussions on the principles of the Act. I'll talk a little bit about some of the changes to the new Act that apply to carers in particular, and I think that's really important to try and get that information out. And then finally, I'll provide a sense of what's happening at the Commission with a brief overview of the strategic directions. Then I've got time for questions. So the new Mental Health and Wellbeing Act started on the 1st of September 2023, but was actually passed in 2022. The new Commission is part of a broader foundation of reforms to strengthen the system's leadership, governance and accountability in Victoria's redesigned mental health and wellbeing system. One of the critical features of the new Act has been a pivotal role in realising the Royal Commission's vision for an integrated system. And I think we talk more about that, and I think we're starting to see movement. I'd like to think that we're going to hit a peak very soon, and that cultural change is going to come in. The Commission is an independent statutory authority that will hold government to account for the performance, quality and safety of Victoria's mental health and wellbeing system. Under the Act, the new Mental Health and Wellbeing Commission has a number of important functions and powers. Sadly, we don't have time to go into all the details of these, but what I do want to highlight that we are responsible for is promoting the improvement, awareness and understanding of mental health and wellbeing across government, business and the wider community, elevate awareness of the lived experience in the community and support leadership and participation of people with a lived experience in decision making, lead and support initiatives to prevent and address stigma related to mental illness, monitor and report on the performance, quality, safety of the mental health and wellbeing system, including the use of restrictive interventions in mental health and wellbeing services. Receive complaints by consumers and carers on their experience in accessing the mental health and wellbeing system and endeavour to resolve those complaints in a timely manner. We're going to promote effective complaints handling by mental health and wellbeing service providers, make recommendations to the Premier, Ministers and Heads of Public Service bodies, promote and support compliance with the Act, and report significant breaches of the Act to the Health Secretary. And perhaps more and most significantly for everyone here today, one of our main functions is to promote the role, value and inclusion of family, carers and supporters of persons living with a mental illness or psychological distress in the mental health and wellbeing system. Ta-da! That's us. Feel free, this is yours. This is not an exhaustive list of our functions and powers, but it does give you an indication of the breadth of our work and an opportunity that exists for the Commission to create meaningful change in the mental health and wellbeing system. As you can imagine, these functions require the Commission to work in close partnership with others in the sector. Our ability to promote and highlight the role of carers is something that we will be working with Tandem and the carer networks to achieve. Sorry, I'm just not sure where I'm up to on my... Thank you. So this is a picture of all the commissioners. The creation of my designated role as the Commissioner, Lived Experience Carers, underscores the Commission's commitment to ensuring the voices of carers, supporters and families are acknowledged, valued, respected and uplifted across every aspect of the Victorian mental health and wellbeing initiatives. Opportunities to harness the potential of the newly enacted legislation. Family and carers dedicate 106 million hours annually, often unpaid, to mental health support, care and assistance. Along with consumers, carers, families and supporters too must be at the helm of all decisions and have the right to have their voices heard. For me, carer sovereignty is about the right and agency of carers to be heard, recognised and respected by services when supporting someone with a mental illness or psychological distress. The Commissioner's roles. The Commissioners will always make decisions together, act together, work side by side, but recognise that we can use our own individual skills, positions and passion to lead the work that we need to do. Treasure Jennings is the Chair Commissioner. She's designing and developing our approach to compliance. Annabelle Brenner, in the green jacket, is doing the design and development of the Commission's reporting and monitoring framework and our approach to systemic reviews and inquiries. Maggie Toko, for whom I'm sure many of you do know, in case you didn't, will be translating the mental health and wellbeing principles from the Act so that everyone can understand and follow them, enable and hold them to account, and engage with consumers, consumer groups and peaks and service providers across the system. And me, well, I'm engaging with carers, carer groups and peaks and service providers across the system in designing and developing our approach to lived experience leadership and to promoting carers. So where do we begin? So our lived experience priorities, we'll be creating a lived experience plan that articulates how well the Mental Health and Wellbeing Commission will elevate the lived experience leadership and participation. We'll also prioritise our work in the lived experience space, including system stewardship, holding the government to account for addressing gaps in the system and lack of coordination, creating a plan to develop more community leaders, providing a platform to increase their exposure to the system, broaden and elevate more voices will also help to reduce stigma and discrimination. Holding government to account for the implementation of the Royal Commission recommendations is a very easy sentence to say, but a hard thing to do. We will also be reviewing and evolving our approach to making and delivering recommendations from complaints handling and create transparency in how complaints are informing system change. We will embed a range of mechanisms that will enable lived experience and lived experience expertise to inform recommendations and focus predominantly on discrimination and stigma in services, and also engage the business community on how to support employees, leveraging the reach and influence and expertise of others to provide us all with mentally healthy, safe workplaces. We will bring these concepts to life in an intentional manner, rather than duplicating other lived experience frameworks. This plan will draw on the important work of the Royal Commission and the other organisations and entities such as the interim regional boards who are doing some amazing work in relation to lived experience. I'm going to move on. I wanted my talk to be a little bit of some practicalities for people. And so I try and include principles and some small changes that have happened to the Act so that each of you can walk away with something practical and then have some greater understanding of how the new Act might impact you and your care of yourself or your loved ones. Sorry, just taking a moment. So here are the principles of the new Mental Health and Wellbeing Act. And I would highlight the 13 distinct principles, but the ones that are probably of most significance are dignity and autonomy principles, diversity of care principles, least restrictive principle, supported decision-making principle, family carer principle, and then at the bottom, the wellbeing of dependent principle. I think for me, probably the most significant is the one around the family and carer principles. Because if you are the nominated support person, you should be told in intake, discharge and changes to treatment, you should be informed by your treating team now of those changes, and they should be taking into consideration what your opinions are and articulating that into their plan. So some of the key changes include scope to allow complaints from family carers and supporters in relation to their experiences in those roles. And I'll ask Kaaren to answer some questions on that, for which I'm sure you all have. New grounds for complaints, a failure to comply with the mental health and wellbeing principles, acting inconsistently with complaint handling standards. We also have new own motions of power for investigations with respect to any matter that a person is able to make a complaint about. We have new powers to conduct an inquiry, and that report goes to the Minister and Secretary. Since the new Act has come into effect, there have been some practical changes to processes that are good to be aware of. The nominated support persons form has now changed to, the nominated persons form has now changed to nominated support person form. And the Act clarifies the role of the nominated supported person is to advocate for the views and preferences of the patient and support them to communicate and make their own decisions. Another important change is the Act removes the requirement that an appointment of a nominated support person be witnessed by an authorised witness. Under the Act, that can now be witnessed by any adult. And now, a mental health service must take all reasonable steps to support the nominated support person in their role. As a carer, it might be worthwhile talking to your loved one that you support about whether they would like to nominate you as a support person. More information on this and the form can be found online, and I will leave a link to that for you. I'm moving on to advanced statement of preference form. Similarly, there have been changes to this advanced statement of preferences that are good to be across. Advanced statements under the 2014 Act has been renamed now to the Advanced Statements of Preference in the new Act. And as with the nominated supported form, advanced statements are also no longer required to be witnessed by an authorised person and can be witnessed by any adult. It's also worthwhile thinking about on that preference form, if your loved one puts you down and nominates you as a person who can make a complaint, that's really useful for us back at the Commission, because then you can act on their behalf. And the other greatest change is a designated mental health service must also ensure all reasonable efforts are made to give effect to that statement. So they are really obligated now, and you have real powers to query, have they looked at those forms? Are they doing what has been written on it? An authorised psychiatrist must provide written reasons within 10 business days whenever a treatment decision is made that does not accord with the treatment preferences expressed in an advanced statement of preference. 10 business days, you have the right. The new Act also clarifies that statements can include preferences about any aspect of care and support, not just treatment preferences. You can find the advanced statement of preference documents and more information in the Act handbook that is on the Health Vic website. Again, this is something that you might want to think about when updating your new forms and ensuring that the treating team have a copy of them. At this point, I'm going to pause and say that I'm going to leave a few minutes now, questions around complaints while Kaaren is here. She's going to come up and join you. Oh, might even get you to swap around.
Thanks, Jacqui. Hi, excuse me. Sorry. Hi, everybody. There may be some questions from the people who are here who are here today, but there may also be questions from people online.
We'll hopefully put some questions in the chat, which we can check. That's okay.
Sure.
And they're not, but maybe we can take a question here first. You had, yeah.
I have a difficult situation. My son developed as part of his story, because everyone's got a story now, he thinks. So he's arranged a lot of fiction in his story. And one thing in his survival mechanism is that I'm not his birth mother. So for me to be able to say that I'm his nominated support person is going to be tricky, because he's been allowed to have that fixation with his treating team from 19 to 44. And that's his survival mechanism to separate from me and say that I can be targeted in an abusive attack. And the team know that he's attacking me quite often, but they've sided with him. And yesterday, the case manager said, "Can you get away from your mother?" Now, I've looked after him from 19 to 44, and I don't need any more of this separation, and a disgusting one at that. I just don't, how can I get round the fact that I even went and talked to the NDIS extensively. I was supported as his nominee, and then he refused. And that is his way of containing himself, his whole survival mechanism.
It's a tricky question. I'm not sure whether.
No,
Are
it
you
sounds
okay
like a
to
really awful
respond?
situation. It sounds like a really awful situation. Sure.
And he thinks that vital and valuable in his story.
Sure. Absolutely. And I.
One thing that I think is disgusting in the public health system. I have lived in the Eastern Suburbs. We're part of Eastern Health. I gave birth to my child at that hospital, and you think that they could just tee up with records to say, "Look, your mother gave birth to you here." You know what I have to do now? If I want to give him any details of my birth, I have to get his adult permission. Now, how can you get adult permission of a 44-year-old when they weren't present as a newborn? Nothing actually makes sense.
Thank you.
There's no sense. There's a sensibility in society.
You're okay. Okay. I'm not sure how you can respond. There's a lot of issues there you brought up, I think. Yeah. But okay.
And against the actual people.
Okay. I might need to catch up with you after Is it okay if we catch up afterwards? Yeah, and we can talk through this a bit more. Okay. Okay, unfortunately, I'm sorry, but we need to move on because there's some other people with questions.
Sure.
Okay.
And I guess just one comment while someone else is getting ready to ask a question is, we receive complaints from people who say that staff in services want to engage with them at the beginning of their family members' episode of care because they want to know what it is that's brought the person to hospital on that occasion, and then subsequently they're not included in aspects of the person's treatment and care. And I know that doesn't completely answer your question, but in terms of the difficulty that many people tell us that they experience, particularly with adult family members who can make their own, on the Facebook, make their own decisions about information and information being shared with others, how complex that is.
See, everybody's got a picture of mother. And when people come from a subjective point of view, most people are thinking that I'm trying to be, as a mother, a manager of my son, a global manager. There's no room for any diversity of understanding of adult relationships. It's all held back as adult child.
It's a really good point. Yeah, it's a good point.
An adult child and
Yep.
parent. When you're both grown up.
Unfortunately, you're not going to be able to heard online.
Absolutely.
So, yeah, okay. We will need to move on, but I'm happy to catch up with you afterwards to talk a bit more about that. Hang on a second. We really need to kind of move on, okay?
Can I just add a bit of clarity to this? Anybody that has worked in mental health nursing for as long as I have, since 1974, and I have a PhD in mental health nursing as well too, as related to the carer's experience of caring for an adult child with schizophrenia. And the term anosognosia is something that everybody needs to learn. And if you look at any kind of evidence, if you searched for Almodovar, I'm not sick, I don't need your help, you can look at the research about that to see that there is a way of resolving that, but it needs to be education throughout the whole healthcare system, including psychiatrists who should know about that.
Yeah.
They should, ANOSOGNOSIA.
And that book, I'm Not Sick and I Don't Need Help, is a really important book. Yep. Yep, absolutely.
Okay, thank you. I'm just a bit wary of the commissioners being able to answer all your questions now, but I guess if you've got some issues, so I'm happy to collect them for you as well, and we can do it in a more kind of organised way.
Sure.
Okay.
I'll just say I'm having trouble hearing. It's probably me, but can people please?
I apologise. Is that better?
I'll be loud now.
Excellent.
Kaaren, a very simple question. Could you talk us perhaps through just what happens if someone calls and they identify as a family carer?
Yep.
And let's throw a twist in there. There's no consent
Yep.
from the consumer,
Sure.
so they're trying to understand how they can make a complaint. And I think in the first instance, most people will be making a complaint on behalf of the person that they support. So I guess I'm just wondering what happens. They call,
Sure.
who are they speaking to? What does it go back to the service? Like, what's the process?
Yep. Is this the right space for the up? Better? Is that better? I might have to hold it.
Closer the better.
Got a mind of its own.
Just
I'll
think
hold
you're a rock star and you've got to really.
Excellent. So yeah, somebody calls, and so if someone calls our 1-800 number, or reverbing, then they speak to a resolutions officer, so a person who's got experience in working with people on the phone, and in looking at the most appropriate, most helpful way to assist a person to resolve their concerns. So if somebody rang about the experience of a family member or someone they're caring for, then one of the questions would be whether or not the person consents to us speaking with the person using the service to seek their consent. So sometimes the person who rings says, no, I don't want you to ring my family member. And so if either we don't have consent to speak with them, or we do speak with the consumer and they don't give consent for that complaint, bearing in mind that oftentimes the views of people who use mental health services are different from the views of people who care for those people, often, and particularly with respect to treatment and the nature of treatment, where treatment should be provided. And so we need to hold that tension in terms of trying to progress the resolution of a complaint, given the Mental Health and Wellbeing Act continues to put the person who uses the mental health service at the centre of all discussions and decisions about treatment, care and support. So given that, if someone who's not the consumer makes contact, if either they say, don't call my family member who's using the service, or we do and they don't consent, what we usually do is facilitate the concern to the service with the caller's consent. Sometimes people who ring us say, no, that's all right, I'll ring the service myself, or I'll speak with the case manager or the key worker or the treating psychiatrist or the nurse unit manager, depending on the relationship. Sometimes people will say, well, I've tried that and I haven't got what I wanted out of that discussion. But because we don't have consent, our only option in that circumstance is to facilitate the concerns. And I'm really mindful of a comment that somebody made at the beginning of the discussions this morning about how different things are across the state and actually just across metropolitan Melbourne in terms of the way services respond to those kinds of facilitations, in that for many services, that's fine. It's as though the person made contact themselves with the service and our office is not formally taking any action. For some services though, the feedback we get is that it's really difficult for a family member or carer to contact somebody and make their own complaint, either about their own experience or on behalf of someone. And we struggle with that because if we don't have consent, we're a bit hamstrung in terms of what else we can do other than provide feedback to services where staff say, we can't progress that complaint. We escalate those things as much as we can as part of quarterly meetings that we have with staff, senior staff in mental health programs. And we also escalate that in our discussions with the Office of the Chief Psychiatrist. So those are the steps that we take. If a person who's a carer or family member, just in response to Jacqui's point about the new parts of the Mental Health and Wellbeing Act, which allow a carer to make their own complaint about their own experience under some circumstances, from our perspective, the legislation says something like in circumstances that are not material to the consumer. So from our perspective, we would think that means a service doesn't need to look at the person's health record in order to respond to the complaint. So the complaint might be a staff member was rude to me, a staff member was dismissive of me, a staff member did not listen to my thoughts, views, worries about the current situation. It might be that that the person who's making the complaint does not feel that staff at a service assisted them and supported them in their role as carer. Might be they were not assisted to see their family member, or there was no access to see their family member in a way that was private and comfortable for each person. But anything that would require a service to look in the consumer's health record, from our perspective, is material. And that also includes all of the aspects in the new Mental Health and Wellbeing Act that require a carer family member to be notified, because it would mean needing to look in the person's health record. Does that answer your question? So you tell me it's a simple one, and I do a lot of hand waving and talking to answer.
Hang on a sec.
That's yeah. So we've put a lot of time and energy into thinking about the way that we could interpret the legislation that as widely as we can, given materiality, is contentious. But for us, if someone needs to access the consumer's health record, then it would have to be seen to be material. Yeah.
I think I just want to acknowledge the explanation is really wonderful. It's not an explanation we hear very often.
Okay.
And it's about time, with a very considered, and also talking about that tension that you have and the limitations that they're on, but what also we can do, I think is,
Yeah.
I wish we had recorded it because it was a really lovely kind of address.
I believe it might be being recorded, and I'm sorry if I sound a bit like a
I
chipmunk.
hope so, but it was just really, thank you. Because it's such a vital question, but I want to keep moving. We've got
Go ahead.
Jacqui here.
Hi, thank you. I'm just wondering in terms of carers engaging with the Commission, I've come across something by the Department of Health called the Non-Legal Mental Health Advocacy
Yes.
Service and Opt-out Register.
Yep.
The protocol. And on page 17, when it comes to involvement of families, kin, carers and supporters, it says upon meeting with the consumer, IMA and the consumer will decide the degree to which the consumer wishes for family, kin, carer and supporter involvement. I would like you to talk.
I'll do my best, but independent mental health advocacy, IMA, is not part of the Commission. It's not part of the Department of Health. It's part of Victoria Legal Aid. And you may have already had some individual and collective experience.
We actually had a presentation by them.
Fantastic.
Yeah.
Fantastic, great. And so 6 weeks, there's been 6 weeks, nearly 7, of operation of the non-legal opt-out advocacy program, and independent mental health advocacy, as far as I'm aware, have had 5,000, I think they said, calls over 6 weeks. Significant number of contacts, which is a reflection of the use of compulsory treatment across the state over the last 6 weeks, apologies. So they're continuing to roll out their programs, but because they make contact with everybody who is being treated as a compulsory patient, generally in an inpatient unit, but not just, also in the community, they say they've had some really, really good interactions with people, and the non-legal advocacy aspect has been really helpful to them, but also the notification requirements in the Mental Health and Wellbeing Act. So there's a requirement that they are also notified when compulsory treatment's used, but there are also parts of the Mental Health and Wellbeing Act that I think that you've just quoted that talk about notification to family members and carers and others once there's an initial discussion with the person from independent mental health advocacy.
Sorry to speak there. And I think that's something that concerns us. I think it's the wording in that protocol that IMA decides with the person. And that seems a little unusual in terms of that it's already implying the family is excluded because someone else will make that decision with them for that person.
Sure. Again, I can appreciate the tension. I can give that feedback to IMA, but it might be helpful if you are also in a position to give that feedback to IMA, given it's in the protocol by the sounds.
We'll keep moving on.
Sure.
Sorry.
Thank you. I do have a question, but just on the protocol, the IMA protocol, I have actually had a look at it. So myself, Ali and Joe are working on the app project.
Oh, great.
So we are following that up and raising it with respect to, so yes, I did get your email, Jacqueline. So just to reassure you that, yeah, we're also connecting with people within the department just to
That's great.
see what we can do there. But I just had just a quick question, and Kaaren, I may, with regard to obtaining consumer consent before a family care supporter, complaint can be made on behalf of the consumer. I think I may have read in the wealth of information that is out there, possibly in the handbook, but that there may be, there may be exceptions. Things might be explored if there are exceptions to that rule.
Yep.
Just wondering if you could
Sure.
say what that might look like.
Thank you. Yeah. So if there are formal arrangements in place, so if there's a guardianship order in place, if there are other arrangements around shared decision making, if, as Jacqui said there's an arrangement in the person's nominated persons form or in their advance statement of preference, and particularly around arrangements around making a complaint. So being able to make that clear is really helpful. The other opportunity for us to consider accepting a complaint without a consumer's consent, so under special circumstances, might be if they're a child or in the very early stages of teenage years. We wouldn't put an age on that because there are many 13-year-olds who absolutely make their own decisions and would give their own consent or not to particular circumstances, and there might be 15-year-olds who may not be in a position to do that. So we don't put an age on that specifically, but for people who are not in a position to give their own consent, where that might be related to a medical condition. So they might have a delirium, they might be unconscious, who just may not be able to give their consent at that time. We might consider accepting a complaint, but we might also suggest to the person who's made the complaint under those circumstances that perhaps they could wait until the person's in a better position to participate. Because I guess the difficulty for us in accepting a complaint when we don't have the consent of the consumer is it can really affect the resolution of the complaint. Because again, we're not entitled to any health or personal information around the person's circumstances, and often there's a lot in what the person's making the complaint about that's important in terms of health and personal information. So because we can take a complaint within 12 months of events having occurred, we would hope if there's a short-term issue for a person who uses a mental health service to be involved, that there might be time for those things to resolve and for them to be asked or given an opportunity to participate. And so the process that I've just outlined in terms of how we would facilitate a complaint without consent could still stand, even if the person is not in a position to give consent at that time. Hopefully that answers your question. Okay, great. The other thing just to add is we can also consider accepting a complaint after 12 months after the events, but there needs to be a good reason for the delay. I think that's what the Act says, a good reason for the delay. And we have a fairly low threshold for what a good reason is, because often people tell us they were recovering, you know, from the symptoms of their illness or the situation.
Thank you for your, I'm sorry we're putting you under the grill here, aren't we, really, a little bit? But these are just seminal issues that I've heard for the last 40 years, and they're still challenging. Even with a new Act, they're still incredibly challenging. So thank you for, but we've got enough time for a few more questions, and then I need to also read a question out from online. So
Sure.
I've got two more lined up now.
Hi, thanks for this. Look, I just have a question about the huge divide between private psychiatry and inpatient care and public. My son, just very briefly, my son, when he was unwell, was told that there wasn't sufficient. They didn't have any psychiatrists in the public system where we live at the time.
Right.
Couldn't get a case manager. They just didn't have the resources, so that was that. So it left us no, well, we no choice. Other than to engage private psychiatrists. We've been through a few of them in order to find somebody who we believe is reasonably good. But they all seem to be a law unto themselves, as do the private hospitals too. And I'm just wondering how that gap is going to be addressed and how they're going to be made accountable as well. Thank you.
Absolutely. So we have a number of calls from people who are in a similar situation in terms of their family member not receiving a public mental health and wellbeing service, who contact our office because our office is sort of at the top of a Google search, really. If somebody types in mental health complaints, generally that's what comes up. And it is, I can only imagine how difficult that must be, because we can't take those complaints at the moment about private practitioners and private hospitals. So private practitioners, concerns about private psychiatrists or other medical practitioners or other allied health practitioners go to the Health Complaints Commissioner. They have jurisdiction for those complaints. And if there are concerns about the conduct and practice of a registered health practitioner, which is 17 health professions, that can also go to the Australian Health Practitioner Regulation Agency, AHPRA. They're the regulator. They're the national regulator of the conduct and practice of registered health practitioners. So when you think about the range of health practitioners who work in mental health services and particularly in private practice, psychiatrists, psychologists, occupational therapists, social work's not a registered profession, but all the other health and mental health professions are regulated. And people can make a complaint about a social worker also to the Health Complaints Commissioner.
Okay, we really are asking you for a lot today, but we'll probably, I've got enough time for 2 more questions. And there's one here and I've got one online as well. Is that okay? We've sort of dragged you a bit longer than, but I think this is just such a really important moment that if you're okay, we've got, yeah, okay, 2 more.
Thanks, Jacqui and Kaaren, for being here. I've got a question for both of you. Jacqui, you were talking about keeping, everyone to account with the Royal Commission reforms and everything, and bringing it back to Andrew's presentation before. Oh, sorry, that's better. Yeah, sorry, those people online that couldn't hear me and people here. There's 2 major reforms that have been delayed, the health-led response and the emergency restraint kind of response as well. Is it your job to keep the government to account on those? That they can't be delayed any longer than what they've already said?
I think automatically I would say yes, with a caveat of I understand the rationale and we can shine a light on that in our and report about this was what was said, this is the reasons, this is the rationale that was given to us. I think that is explicit in itself because you're asking decision makers to explain why there was a delay. And I'm sure that that's not completely satisfactory to perhaps everyone, but I think we hold people account, we give people opportunity to explain, but if we consistently see something that's been delayed and delayed and delayed, I think that's when we'd probably escalate it. In relation to the restraints and restrictive practices, there are, within the department, there are goals that safer care and services are actually opting in to actually start reducing their use of chemical restraint and restraint practices by 20% over a period of time, and they'll be reporting to that. We're also waiting for the, out of the department, a framework about monitoring and, reporting, and we will be using some of that data, but they are important points, and hopefully that has answered your question to a degree.
It has. I'm hoping that you guys are keeping an eye on them. That's all.
Absolutely. And just to add to what Jacqui's saying, from our perspective, the commencement on the 1st of April of the use of the application of the Mental Health and Wellbeing Act in emergency departments will be integral to many of the complaints that we already take from people or about people, where restrictive interventions are used in emergency departments either under the mental health legislation or in the absence of legislation, which means people have no protection. So the person who's being restrained does not have access to their rights under the Mental Health and Wellbeing Act.
Okay, thank you again. One last question, if that's okay. It's a lived experience question. I'll ask this on. This is from online. How does the Commission incorporate lived experience in its operations? For example, do they have an advisory group of consumers and family carer supporters to support that process? I think that's a Jacqui question.
That is a very great question, and I'm happy to say it's not even a Dorothy Dix because I can answer that one very quickly. We are because we're a new commission, we're looking at the way we collect and engage with family carers and consumers to advise us. And rather than going down the pathway of an advisory group, we're looking at developing relationships with people who have sort of specialised understanding of certain areas. So someone who's been in restrictive practice, we would look for people who have actually had to look as carers and also patients. And so that diverse group is going to be more of a working network where we'll reach out and encourage people to join and to participate, but we're not going to have one formatted sort of council or advisory group. In relation to the everyday being of the commission, we do bring a lived experience lens. Tammy here is am I correct in saying your senior project? Senior, what is your title? Senior advisor, so sorry, 6 weeks in. Senior advisor, and she has a lived experience of carer, but we also have a consumer, and we're looking to recruit in our lived experience sort of, I guess, pillar of work, people who do and encourage people to come who have a lived experience or a living experience, which we think is really important.